Good evening, everyone. This is Dr. Vineet Sehgal, and welcome to our Let's Crack NEET PG YouTube session on endophthalmitis, a very important topic for the clinically relevant exams, also, as well as for your NEET PG, as well as for your third year students. So, I think many of the interns are also joining this session. So, this session would be also useful for you so that how you basically work out these patients who need emergency care in ophthalmology. Okay, so I am your ophthalmology educator, Dr. Vineet Sehgal, and you can see all my lectures live and exclusively on the Unacademy Learning app. You can just download it on the Play Store, and there you can see my special classes also, which are free of cost by applying a code that is OPHTHAL10. Okay, so you have a lot of plus courses which are going on. You can register for that courses if you want to basically focus on the PG. You can basically join any of the educator and basically follow him throughout the Unacademy Learning app so that you can get the best of the knowledge. There is a very important thing that I want to tell you, that there is a iconic subscription also. So iconic subscription, you are having the advantage of the plus courses that have the special classes, as well as you can have the iconic courses subscription where you would have a advantage of the plus classes, as well as you would have the advantage of the prep ladder app where you can get video lectures, recorded video lectures of the topmost faculty. You can get question bank 2.0, rapid revision course, and the handwritten notes. And how you can do, take a 10% discount by using my code OPHTHAL10. Okay, with this I would like to start my session on endophthalmitis. So just give me a thumbs up so that I can understand that you are seeing my videos as well as my voice is audible to you. Okay, so Rahul, endophthalmitis. The word endophthalmitis, you can understand it by breaking it into two parts: end and ophthalmitis. Okay, so coming to the, let's say, end of the eyeball. So can you see that from the word itself, it basically means this is an ophthalmic emergency. This is a end stage ocular disease. So can I say with this that this is a ocular emergency? Do you understand the point? So इसका जल्द से जल्द ट्रीटमेंट बहुत ज़रूरी है, नहीं तो आईबॉल हमेशा हमेशा के लिए ख़त्म हो सकती है, आपकी विजन हमेशा हमेशा के लिए ख़त्म हो सकती है. ओके, नाउ how would you get a patient in my OPD who may be suffering from endophthalmitis? So let's say he have got a cataract surgery on the 20th of March. 3 days post-operatively he comes that, sir, first day I was absolutely fine, but after 3 days I was having pain and redness in the eye. As with that I am also having a decrease in my vision. Okay, so यहाँ पर क्या क्या चीज़ें आपको ध्यान रखनी है. So it may not be coming on the first day post surgery. Okay, first day post surgery maybe the patient is absolutely fine. He may be getting it 3 days or 5 days or 7 days after cataract surgery. Then the patient may have pain and redness. Okay, why the patient have pain and redness? Because of the inflammation of the uveal tissue. What are the various uveal tissue? Iris, choroid, ciliary body. There may be inflammation there. There may be a uveitic component. So patient को pain, redness होती है और जिसकी वजह से patient की vision down गई है. Okay, so at first day post operatively he may be having a 6/9 vision, but on third day he may basically drop to 6/18 or 6/24 vision. This is something, a clinical scenario of a patient who is suffering from endophthalmitis. Now endophthalmitis basically have a DD. DD means differential diagnosis. So जब भी patient को आपके ये situations आती हैं, the patient may be having a post cataract surgery, having a decrease in vision with pain and redness. He may be suffering from TAS or endophthalmitis. Can you tell me what is the full form of TAS? कभी आपने सुना है? So TAS basically TASS, that is toxic anterior segment syndrome. Okay, this is the full form of TAS. We would study more about TAS in our coming slides. Just remember, if they ask in your viva what is the differential diagnosis, you say that sir, either the patient may be having a TAS or may be having a endophthalmitis. Okay, chalo. So what are the various anterior segment signs that you would get? So there is a difference, Rahul, between the signs and the symptoms. Sometimes the examiner asks what are the signs and what are the symptoms. सो सिम्टम्स आर व्हाट द पेशेंट परसीव्स. ठीक है, पेशेंट आएगा और वो तुम्हें बोलेगा सर मुझे लाली हो रही है और दिखने में थोड़ा सा कम दिखाई दे रहा है. तो दीज आर द सिम्टम्स. What is the meaning of signs? Signs means when you are basically seeing him on the slit lamp or on the direct or indirect ophthalmoscopy, you are seeing the patient is having uveitis. So the patient is having cells, flare, KPs. So all these are the anterior segment signs. Okay, so like uveitis, you can have cells or flare. Hypopyon. Hypopyon means pus in the anterior chamber. Then the patient may having a corneal edema, and the patient may have, because of the severe uveitis, patient may have increased intraocular pressure. Okay, so patient may have increased intraocular pressure. These can be the signs of the patient suffering from your endophthalmitis. So endophthalmitis ko you can say that it is a type of a infective uveitis which is basically involving the anterior segment as well as the posterior segment. Okay, so the sign in the posterior segment is the patient may have a inflammation of the vitreous. What I call it vitritis. And the patient, subsequent to the infection of the vitreous cavity, the patient may have changes in the retina. So there can be, in final stages, retinal necrosis. So that is why this disease is so important. It can basically spread to the retina and the choroid, and it can severely affect the seeing capacity of the patient. Okay, so these are the anterior and posterior main signs of endophthalmitis. So when this patient would present to you, what would be your follow-up? What would be your strategy to treat the patient? First thing is, you would basically go for a B scan. What is the meaning of B, Rahul? So this is a USG B scan. The word B means here the patient is having a USG brightness scan. So if you can see, this is your coats of the eyeball. Okay, and if you can see these, can you see these exudates, these mild opacities in the center of the vitreous cavity? This area is the vitreous cavity. Okay, vitreous cavity, you are seeing these whitish spots. These are basically called exudates. Okay, so if you can appreciate, there is a scan also done here. Okay, how you can say A scan? Because you are seeing these spikes. Can you see the spikes? Just give me a thumbs up, Rahul. So Shafaq, these spikes they basically tell the amplitude spikes. So the large spikes that you are getting, this is because of the lens shadow. Okay, and then you are seeing large spikes here. They are basically from the coats of the eyeball. Can you appreciate these small spikes? Can you appreciate these small spikes? So these small spikes, they are basically, Dr. Anwar, because of the vitreous exudates. Okay, so this vitreous exudates, this can be either a endophthalmitis or it can be a vitreous hemorrhage. Just by looking at the B scan, you cannot comment that whether it is a endophthalmitis or it is a vitreous hemorrhage. But if the patient is having infective signs also, remember, a vitreous hemorrhage patient would not come with the signs of uveitis, but a endophthalmitis patient would come with the signs of uveitis. So शफाक, मैं एक बार फिर से एक्सप्लेन कर देता हूँ कि अगर आप बोलोगे सर ऐसी तो विट्रस हेमरेज में भी मिलती है, तो क्या डिफरेंस क्या है विट्रस हेमरेज और एंडोफ्थेल्माइटिस के यूएसजी में? तो नॉर्मली आपके स्टेज पे अगर आपके पास एंडोफ्थेल्माइटिस पेशेंट आता है तो उसमें आपको यूवेइटिस के साइंस भी दिखेंगे, जैसे आपको इन्फ्लेमेशन दिखेगी, जैसे आपको कैरेटिक प्रेसिपिटेट्स मिल सकते हैं, सेल्स और फ्लेयर मिल सकते हैं, बट विट्रस हेमरेज के पेशेंट में आपको ये चीजें नहीं दिखाई देंगी। इस तरह से आप दोनों को डिफरेंशिएट कर सकते हो, ठीक है ना। आफ्टर डूइंग अ ultrasound B scan and confirming the diagnosis of endophthalmitis, you come to the management. So the management, the first step that you do is you basically give the patient fortified antibiotics, ठीक है। सो यहां पे मैंने लिखा है fortified antibiotics। fortified का क्या मीनिंग है? fortified means that I have freshly prepared very concentrated एंटीबायोटिक्स दैट आई एम गिविंग टू द पेशेंट। सो इससे फायदा क्या होता है? इससे फायदा, वेलकम डॉक्टर शौर्या, इससे बेसिकली फायदा ये होगा कि एक तो वो प्रिजर्वेटिव फ्री होंगी। द सेकेंड मेन एडवांटेज डॉक्टर शौर्या हियर इज दैट दे आर हैविंग मोर पोटेंसी एज कंपेयर टू योर स्टोर्ड एंटीबायोटिक्स। ओके, सो आई मे गिव देम concentrated cefazolin eye drops, concentrated vancomycin eye drops, or concentrated tobramycin eye drops, which I have basically freshly prepared in my OPD. Okay, and as you know that whenever we have uveitis we give atropine or hometropine, so मैंने उनको patients को cycloplegics पे भी on कर दिया। Okay, so I use both cycloplegics as well as fortified antibiotics, and for if there is any increase in the intraocular pressure, I can give the anti-glaucoma medications also to these patients. Okay, मैंने anti-glaucoma medications भी उस patient को start कर दी। Now, is this the all which we have to do for a patient of endophthalmitis? Definitely no. हमें प्रॉपर ट्रीटमेंट करना है। अभी तक जो हमारा ट्रीटमेंट स्टार्ट हुआ है वो हमने एंटीरियर सेगमेंट के ऊपर कंसंट्रेट किया है, लेकिन जो विट्राइटिस है, जो इन्फेक्शन है, वो तो विट्रस कैविटी में भी आ गया है, तो हमें और क्या करना है? The next thing that I would do is I would basically give the intravitreal antibiotics to the patient. Intravitreal antibiotics, how I give it? I basically take it in a patient who is having a pseudophakia. Pseudophakia का मतलब pseudophakia, लेंस जो कि एक नॉर्मल लेंस नहीं है, जो नेचुरल लेंस नहीं है, उसकी जगह हमने इंट्राऑक्यूलर लेंस पुट किया है, तो उसको बोलते हैं pseudophakia. Okay, now what I do here is I basically do take 4 millimeter. Can you see this one? So I am basically taking a mark 4 millimeter from the limbus, and then I am putting a injection there in the vitreous cavity. Okay, so I just make it a diagram here. So I am putting the injection in the vitreous cavity 4 millimeter from the limbus, so that it can directly come under the vitreous cavity and it have effect. So see, you may get something like this. So see the video. So after basically seeing the 4 millimeter mark, I am putting the injection. Can you see with the 30 gauge needle? I am putting straight in the vitreous cavity. If you can see this video and you like this video, just give me a thumbs up. I repeat it again. So I take a 4 millimeter mark. After taking a 4 millimeter mark, perpendicular to the limbus, I am basically putting the injection straight into the vitreous cavity. This is basically a intravitreal injection. Now Rahul says that, sir, you have put 3 intravitreal injections in the patient, maybe after every 24 hours, but the patient is still not responding. What would you do next in these type of patients? What is the next course of action? The next course of action in these patients is that we go inside and remove all the infective vitreous, and you can put a oil there or you can put a gas there. Okay, so that the definitive area where the microbes are basically replicating again and again, where even my fortified antibiotics are not basically going on, there we can basically remove whole of the vitreous like we do in a retinal detachment. And after removing the whole vitreous, I put a oil or what I do is I put a gas there so that the area where the microbes are basically replicating, that is taken care of. So this is a video of a vitrectomy that is going on. Can you see here? Can you see the retina? So we are basically putting a illuminator probe as well as cutter. Okay, so what it is doing is it is basically removing the vitreous, and one probe is basically putting the light and the other probe is basically cutting the vitreous and taking care of it. This is a vitrectomy surgery. So they would ask you when you are going to do a vitrectomy surgery. So when even when the intravitreal injections are given and they are having no effect, okay, the patient is not improving, or if the patient has come with lot of exudates in the vitreous cavity and the vision is very less, it is hand movement close to face. Okay, so you just tell the patient that is the hand moving. He says, sir, only I am not able to see the finger, but only if the hand is moving. So this is a very bad vision. So Swati, in that cases, what I can do is I can straight away go with the pars plana vitrectomy. Okay, what I do is that whenever I am doing a pars plana vitrectomy, or when I am doing giving a intravitreal injection to see what are the microbes which have caused the infection, I can take a very small part of the vitreous and send it for the microbiological investigation also. So I can say that it is a type of vitreous tap or vitreous biopsy which I do, so that we can basically send it for culture and sensitivity, so that we can get the exact bacteria or the microorganism which is the cause of that endophthalmitis. Okay, so remember, sometimes they ask the question on the basis of most common. This most common is so sometimes confusing, so that's why in my notes also and in my lectures also on Unacademy, I have focused on this most common list. You can go back and see my special classes. You would get the PDF there also, or you can get it from my notes also. But remember, the most common causes are so important for you. I would just revise it for you here. So most common cause of endophthalmitis. Swati, can you tell me? If I tell about which bacteria most commonly causes the endophthalmitis. So remember, it is Staph epidermidis. Okay. Okay. Second question is for Shaurya U. Most common bacteria which can cause endophthalmitis after a trauma. So very good, Rahul. Most common cause post-traumatic endophthalmitis. It is your, anyone? So it is your Bacillus cereus. Okay. The next is most common cause in HIV positive patients or patients who are on immunosuppressants. So most common cause in HIV positive or those who are on immunosuppressants. This was a previous year AIMS question and the answer here is Candida. If they ask, so I write it here if my face is basically obstructing. If they ask most common cause of endophthalmitis in post YAG cap patients, okay, where the YAG capsulotomy has been done for your posterior capsular opacification, then what is your answer? Then your answer is, have you heard about this bacteria? Propionibacterium acnes. Okay, so these are few very important questions which you have to remember. I would basically make you understand again and again by giving a lot of MCQs to you. So one thing more that I want to tell you, that more you practice the MCQs, the relevant MCQs, not the MCQs haywire from any source, the relevant MCQs, the more you practice, the better you would be in understanding the facts. Now, if the most common cause post-trauma is Bacillus cereus or any other bacteria, there is nothing which you can basically understand. You have to cram that. And how would you, and there are lakhs of facts that are there in the ophthalmology, and in the various subjects. How would you cramp each and everything? So for that it comes the help of mnemonics as well as help of solving more and more relevant MCQs. Okay, chalo, let's move to the next part. The next part is, you ask me, sir, it is such a dreaded disease, how would basically we can avoid endophthalmitis? This was a previous PGI question. So remember, for preventing the endophthalmitis, some of the authors have basically advocated the use of topical antibiotics pre-operatively. ठीक है, ऑपरेशन से पहले टॉपिकल एंटीबायोटिक्स देना या फिर ऑपरेशन के बाद जो है सिस्टमिक एंटीबायोटिक्स देना. So one thing that you have to remember is that systemic or antibiotics pre-operatively or post-operatively, topical antibiotics pre-operatively or post-operatively, they do not have any role in preventing endophthalmitis. Are you getting my point, Shaurya? So systemic antibiotics is definitely no in any of the case of endophthalmitis, whether it is a treatment or whether it is a prophylaxis. What are the two things that you have to remember at your level is, the first thing is you have to do a good sterilization of the instruments. Okay, there should not be any bacteria which is there in any of the instrument you are using for a cataract surgery or any intraocular surgery. The second very important point, Swati, is that whenever the surgery is done by a surgeon, he should have a proper surgical scrubbing. Okay, so in surgical scrubbing we have few steps. Okay, like this, you have to basically do a thumb rubbing, you have to take care of the fingers and throughout this. So I would basically demonstrate all the steps of the surgical scrubbing also. At this point of time you have to remember two important points that are for prophylaxis. One is sterilization of the instruments and the other one is scrubbing of the surgeon. Is it clear? Okay, now the next important thing is, I want to have your opinion on two of my questions. So question is, role of systemic antibiotics in treatment, yes or no? I just told you. Role of systemic antibiotics in treatment. I am asking about treatment. So answer is no. You do not have to basically have to give systemic antibiotics in treatment. Yes, we are all doing it, but it is off the label. For the exam purpose, the answer here is no. Okay. Role of pre-operative antibiotics in prophylaxis. Here also the answer is no. Okay. Remember, it is not the systemic antibiotics that we use in treatment, Dr. Shaurya. It is the fortified topical antibiotics that I use in these patients. Okay, very important point that you have to remember. I have seen so many times the students doing wrong these questions. Okay, chalo. The next thing I told you about TAS. The full form of TAS is toxic anterior segment syndrome. Okay, toxic anterior segment syndrome. So what happens here is, let's say post-operatively surgery, after 1 week, patient comes, he says that, sir, I am having pain and redness and I am having diminution of vision. You would think that the patient would have endophthalmitis, but sometimes it is not endophthalmitis. You can see from the word toxic. Toxic means it may be a hypersensitivity reaction. This hypersensitivity reaction can be to any of the agents that we use in the cataract surgery or any intraocular surgery, or it can be because of the instruments that we are using. So they have been autoclaved or they have been disinfected. It can be a reaction to that also. Okay, so basically the funda is there may be a hypersensitivity reaction. Okay, so as you can see here, there is a anterior segment syndrome. So all your manifestations are there in the anterior segment. Okay, now Shaurya, see, you can both in the endophthalmitis and TAS can have a corneal edema. Is it clear, Dr. Rahul, Dr. Swati, Dr. Shaurya, Abdul? So दोनों ही केसेस में आपको कॉर्निया में सूजन दिखाई दे सकती है. टास में भी आपको हाइपोपियन दिख सकता है, कभी कभी दिखाई देता है, कभी कभी नहीं दिखाई देता है. सो हाइपोपियन इज प्लस माइनस, but in endophthalmitis usually you have a hypopyon, so it cannot be a differentiating factor. So you would ask me, sir, how would you differentiate? When you do a B scan, there are no vitreous exudates in TAS. Okay, so there are no vitreous exudates in the TAS, but in endophthalmitis you would get the vitreous exudates. Can you see here? So can you see, appreciate? So this photo would not be there in the TAS patient. TAS में ये नहीं होता है और आपका endophthalmitis में ये होता है. So before starting the treatment, before going with the intravitreal injections, before going with the pars plana vitrectomy, you do a ultrasound. If the ultrasound is absolutely fine, the patient may not be having a endophthalmitis. And as I told you, endophthalmitis is something which is infectious. It can be exogenous. Okay, so exogenous is that you have got a cataract surgery and got a endophthalmitis there, and it can be a endogenous also. So the patients who are suffering from who are immunocompromised or who are the IV drug abusers, so in their cases also, even before a cataract surgery, you can have a pre-existing endophthalmitis there, because they are using sometimes contaminated needles, or if their infection is there in the bloodstream, if there is a sepsis, they can have endophthalmitis. Remember, it is TAS is not an infectious. TAS is basically a hypersensitive reaction. Because it is a hypersensitive reaction, it would basically respond to steroids, whether systemic, topical, any type of steroids, the TAS would basically respond. So अगर TAS का पेशेंट आता है तो आप देखोगे कि मैं उसको प्रेडफोर्ट और डेक्सामीथासोन ये सब चला रहा हूँ, बट अगर एंडोफ्थेल्माइटिस का पेशेंट आता है तो मैं स्टेरॉइड्स नहीं दूंगा. So that is why it is very important to differentiate between the TAS and the endophthalmitis, because treatment modality totally different है. TAS के पेशेंट में आप जो है वो उसको स्टेरॉइड्स दोगे, और एंडोफ्थेल्माइटिस के पेशेंट में आप उसको जो है इंट्राविट्रल इंजेक्शंस, फोर्टिफाइड एंटीबायोटिक्स, और बाद में अगर जरूरत पड़ती है तो पार्स प्लेना विट्रेक्टमी करोगे. इज इट क्लियर एवरीवन? ओके, अब आप पूछते हो कि सर अगर मैंने कुछ नहीं किया, फाइनली क्या होगा? सो फाइनली व्हाट वुड हैपन इज एंडोफ्थेल्माइटिस वुड कम एंड basically get transformed into another term which is called panophthalmitis. What is the meaning of pan? So panophthalmitis means that yes, we all know the uveal tissue, the vitreous, everything would be involved. With that, there would be a necrosis of sclera, so scleral coat. So all the three coats of the eyeball, that would also get involved, as well as the orbital tissue would get involved. Okay, Shaurya? So यहाँ पर तो फाइनली हमारी हद ही हो गई कि आई तो चली गई, आई के साथ साथ हमारा ऑर्बिट भी इन्वॉल्व होना शुरू हो गया. यहाँ पर प्रॉब्लम आ सकती है इफ देयर इज अ ऑर्बिटल एक्सटेंशन. This can then go into the systemic stream and the patient may go into the septicemia also. Okay, so this is a life-threatening condition. And because in the panophthalmitis, you may have a sclera also involved, orbit also involved. So in that cases, you have to give intravenous drugs. Okay, so intravenous drugs, they ask systemic antibiotics. So you remember, systemic antibiotics has to be given in the panophthalmitis and not in the endophthalmitis. Is it clear, Dr. Shaurya? So if you are liking this session, I would just please request you to please hit the like button. Chalo. So with this, I come to the end of my session. And before I end the session, there is a small quiz for you, small MCQ practice for you. Try to answer as soon as possible. So my first question is not a sign of endophthalmitis. Your options are hypopyon, vitritis, iritis, or optic neuritis. So we all know the anterior segment is involved, so we would get hypopyon, we would get vitritis, we would get iritis, but optic neuritis is basically a sign of the optic nerve disorder, so it is not a sign of endophthalmitis. So Asif, the answer here is D. Okay, chalo. Let's move to our next question. Investigation of choice for endophthalmitis. Okay, investigation of choice. Your options are CT scan, vitreous biopsy, USGB scan, MRI head and orbit. So the answer here is C, that is USGB scan. Okay, a non-invasive way of basically seeing the vitreous exudates is your USGB scan. So those students who have joined late, I would just show you a picture of how the B scan is done. Okay, so can you see here? This is the B scan where you are seeing the mild to moderate amplitude spikes in the vitreous cavity. Okay, this is the your investigation of choice. You would ask me, sir, why not a indirect ophthalmoscopy? So in indirect ophthalmoscopy, because of so much haze in the cornea, so much haze in the anterior chamber, so much haze in the vitreous, you would not be able to see the end of the retina, and you would not be able to see sometimes even vitreous exudates. Okay, so that's why the indirect ophthalmoscopy is not the investigation of choice. The investigation of choice is USG. You would say that, sir, in CT scan also you would get this. So definitely, but why should I expose a patient on the radiation when I have something which is a non-radiation investigation that is possible for us? Okay, Dr. Abdul? Okay. Chalo, with this, I come to my next question. Not a management option for endophthalmitis. Your options are fortified topical antibiotics, cycloplegics, pars plana vitrectomy, or intravenous antibiotics. Try to answer. So as I told you again and again that in end ophthalmitis you do not have any role of systemic antibiotics. Okay, so the intravenous antibiotics are not having any role here. The intravenous antibiotics, they have a role in the panophthalmitis where your uveal tissue is involved, your sclera is involved, and as well as you have the infection of the orbit also. Okay, fortified topical antibiotics, cycloplegics, they have to be given. Cycloplegics because there is a uveitis, and pars plana vitrectomy has to be done when the patient is not responding on the various intravitreal injections. Okay, chalo. With this, I come to my next question. Most common cause of endophthalmitis in post-YAG cap patients. Your answer options are Staphylococcus epidermidis, Propionibacterium acnes, Bacillus cereus, or Candida. So the answer here is B, that is Propionibacterium epidermidis. So I revise it once again for all the students who have joined late. Staphylococcus epidermidis is the organism that is responsible if they ask in total. Propionibacterium acnes, this is the organism that is involved post YAG capsulotomy or delayed type of endophthalmitis. Bacillus cereus is the organism which is involved in the endophthalmitis, most common when there is a trauma. And Candida, it is basically the most common cause in the HIV positive individuals or those who are immunocompromised or those who are the intravenous drug abusers. So in that cases you would have the various types of organisms. So basically, Asif, this was my, I think you joined the session late. This was my first slide. Can anyone answer Asif's question? So how would be the patient complaint? Patient says that, sir, after the surgery I was absolutely fine day 1, but on day 3 I am having redness, pain and watering in the eye, and my vision has dropped. So acute onset of decrease in vision with pain, watering, photophobia and the complaints of uveitis. This is the presenting complaint of the patient of endophthalmitis. Okay, chal. So next question is distance of injection tip from the limbus in case of intravitreal injection in a pseudophakic patient is, your options are 2 millimeter, 3 millimeter, 4 millimeter or 6 millimeter. Try to answer. So this is the limbus and I have to put a intravitreal injection. So how far from the limbus I should put it? Okay, what should be this distance? So this distance should be around, very good Dr. Avinash, this should be around 4 millimeter. Okay, so this distance should be 4 millimeter in the patients who are suffering from endophthalmitis. Okay, so next question is patient presented with the limbus to limbus corneal edema with iritis. On USG, it was anechoic. Anechoic means there is no vitreous exudates. And patient responded only to the steroid treatment. He may be suffering from which of the following disorder? Endophthalmitis, panophthalmitis, toxic anterior segment syndrome, or retinoblastoma. Try to answer. So this is basically, Abdul, the definition I told you, toxic anterior segment syndrome. Why it is not a endophthalmitis? Remember, in endophthalmitis, USG would not be anechoic. Okay, the USG would not be anechoic and the patient would not basically respond to only steroid treatment. Okay, so the answer here is C. So just tell me if you want anything else in my presentations. So this is the way I present, that I basically start a topic and after doing a theory part, I basically, because this is your input, that sir, that after doing a theory put some MCQs also. Or you want vice versa, you want MCQs first, theory for that, or you want theory first, MCQs after that. Just give me your opinion in the comment section so that I can improve in my slides, in my videos in the coming days. Second thing, what I want to tell you is that remember, to basically have a failure, this is not a bad thing. Okay, a failure means at least you have tried. But those students or those people who do not try, who do not fail, they do not know what are their mistakes. Every day in the morning when I get up, I make a diary. I basically make a stuff that what are the things that I have to do today and what are the things which I have done yesterday. How could I have improved my input yesterday and how can I do it better today? Okay, so if I have failed yesterday, this does not mean that I would fail tomorrow. So tomorrow is always a new day and always learn from your failures and go ahead. This is the one of the most important thing, and this is the my secret secret tip for you so that you all succeed in your coming days, in your coming exams. If you need anything from my side in ophthalmology, you are more than welcome. You can basically ask the doubts on the various of platforms where I am available, like the Telegram group. I am there also. Okay, definitely, Shaurya, I would take a neuro-ophthalmology visual pathway session also. I am available on the Telegram group. I am available on the WhatsApp group. I am available on the Facebook group. I am available on the special classes. So anywhere in the next coming month, in the month of April, if you have any doubts anywhere, you want any topic as Shaurya has basically asked me, you can just tell me. Thank you very much for attending this session. If you want to join the Unacademy Learning app, you can use my code OPHTHAL10 and subscribe for either the plus or the iconic subscription and get a 10% discount on that. And with this, I basically end my session. Subscribe for the Let's Crack NEET PG channel and hit the bell icon for the notifications. Thank you very much and have a good night.